bioresorbable vascular scaffold. So far, it's a great technology, very interesting, maybe a little disappointing. We've had a meta-analysis of major randomized trials showing no significant difference in one-year clinical outcomes between BVS and second-generation cobalt chromium everolimus-eluting stents. That was from CoCREASE. But the 2-year follow-up results from Absorb-2 presented at TVT last year revealed a higher rate of target lesion failure in the BVS group. It wasn't significant, but it was 7% versus 3.0%. So while not adequately powered for clinical endpoints, it did raise some, concerns. So now we're here to talk about another paper, and I really think this is kind of an interesting one for a variety of reasons. It's in JACC Interventions. It is the August 22nd issue, and it's mid to long-term clinical outcomes of patients treated with the everolimus-eluting bioresorbable vascular scaffold, or the BVS Expand Registry. And for this, I have Robert Jan van Joorns, who is from Erasmus Medical Center, and that's, of course, over in Rotterdam in the Netherlands. The ESC was there a while back in the Netherlands. Man, beautiful, just gorgeous. And in this particular paper, what were you looking at?
So after Absorb-2, we went from a different phase. We went from the selected patient population to a real-world population. We had access to these scaffolds for our regular patient treatment as of September 2012. We had just finished the enrollment almost of Absorb-2, and then we're going to more complex lesions. So what we decided, if we have now CE approval, we can use the device in Europe, we're going to use it in our clinical practice, we need to register all our patients and follow them up for a longer period, because these are different kind of patients versus the official approval patients. So we enrolled all our patients in a registry, and now we have almost 18 months results of these patients available, which is much longer than most of the registries done or the randomized trials.
So what do you have in terms of results?
Oh, first, let me tell you a little bit about the patients.
Okay.
Because we had patients with bifurcations. 20% of our patients have a bifurcation. We had long lesions. The average lesion length in Absorb-2 and Absorb-3 is 11 millimeters. Wow. Our lesion length was 23 millimeters as a mean.
Right.
So, and we had a lot of ACS patients, mainly non-STEMI for this particular registry. So that is different. These patients have not been in a study before. So the results of these kind of patients are in that perspective encouraging, because our ST rate is not higher than Absorb-2 or Absorb-3. Now in general, if you do this meta-analysis as you just mentioned, you see that there's a tendency that there might be higher ST rates using an absorbable device. Why? Maybe I just continue on it. Of course, one of the explanations we potentially see, these are thicker, 150 microns. Right. So they are different to implant. Have a different impact at the acute moment.
Now, there's an accompanying editorial to this that was talking about bioresorbable vascular scaffolds in routine clinical practice. Should we wait longer? And the two authors of the EC are talking about a quarter of the recruited participants in your paper had scaffold under expansion based on quantitative coronary analysis. That seems high.
Exactly. I fully agree with that. Remember, when we did do the Absorb-2 study, we had these first images of disrupted scaffolds. So the whole strategy at that moment has been for quite some time, don't post-dilate and absorb. That was 2012. We started going from the study patients to the real-world patients before we had the experience of Antonio Colombo, who said you have to prepare and post-dilate. So we have post-dilation of 50%, and we have indeed some under-expansion. It was nicely shown by the paper of Tommaso Gori last year. Also, under-expansion in absorbs is a trigger moment for problems.
And it's a known important risk factor for scaffold thrombosis and restenosis, so that's why this is an issue.
Yeah.
Now, they also note that the rate of overall scaffold thrombosis was 2.7% at 18 months, yes, with a definite scaffold thrombosis rate of 1.9%. Those are similar to those observed in the other BVS trials, but it is still a little higher compared to second-generation metallic DES. Is that a concern for you?
No, interesting thing for me, the first thing is, it is not much higher than the Absorber 2 or 3, which are selected patients, 11 millimeter longs, and they have a lot of, now we do bifurcations and long lesions, calcified lesions. We have patients who had been doing rotablators before. So that we didn't go up, I think that is a strong thing first. So if you still compare overall these registries, you see this concern that is still out. What we have learned is how to avoid that with the post-dilatation and the lesion preparation. And now there are coming new studies, new registries, with at this moment short follow-up, who have shown that we can decrease the scaffold thrombosis with an optimal implantation strategy.
I mean, for a while it got to the point where it seemed like the glass was half empty and it might be getting lower, but if you really look at the patients that you're dealing with and the risk that these patients have, I think you can now argue for the glass as being half full, and you may actually be able to fill up the glass a little bit more so that it's going to be more positive as we move forward.
No, I can tell you, we are now enrolling patients in what we call compare absorb, which is a selection of patients we have been defined where we say we will do longer lesions, we will do bifurcation lesions, not extremely complex, no high syntax scores, etc. So we tried to select it, and now we can do that with the optimal implantation strategy. And that one's going to come up with results in a few years. So we still have to wait. But I think what we have learned from our registry, from the GHOST EU, from Tommasio Gori, is that if we change our implantation strategy, it's going to be better. And with this new experience, from this experience we had, is partly how not to do it. And that experience brought us to the good design for the next phase of studies.
And when will those start?
They started, we have 900 patients in compared to, with a target of 2,000. So we should be having them all enrolled next summer.
Very nice. So when will you have some more data for us?
No, what we did do, and I think that's also for me an all important issue, we always talk about non-inferiority at 1 year.
Right.
And I think what we say is that our new technology, is that only non-inferiority. But it's really, I do try to make some comparisons. Looking at the first electrical cars, they were terrible. They didn't do anything. Now we have the new absorbs coming up. If we have something which is totally new, it's plastic, it's sugar, it's not a metal we know for 20 years. If that can be at 1 year the similar thing as our current stents, and we know, of course, that if we keep the facial vessels more flexible, etc., you know, the permanent implants, you don't need them after 1 year. So the whole technology-driven thing, this is the first generation, it's the first device coming to the market. Non-inferiority at 1 year, that will set the target. Every study, absorb 3 and 4 combination, and so far, that's what I mentioned, compare absorb, have non-inferiority 1 year, superiority at 5 years. So I'm happy with the non-inferiority at 1 year because it demonstrates that we can build something totally new, which is as good as this at the moment. And of course, we have to wait for what we think about the future.
Because even the editorial writers were agreeing, saying that the whole idea here is to see what's going to happen in 3 years and 5 years.
Yeah.
And so I think the nice thing about chatting with you is I feel a little bit better now about the technology, because for a while there I was like, oh, this was a big disappointment.
Yeah.
But now it's looking a little bit more optimistic.
So I had yesterday a presentation here at ESC where we looked at the 10 years outcome of our metallic DES. And we see in the end something like people going up to 20% of the patients having re-interventions. Meaning that we have DES, which do extremely good in the first year, up to 2 years. In the end, these implants result in a dysmorphed vessel, in a caged vessel. And that's not going to... Our patients have an average age of 62 years old. Our life expectancy in the Netherlands is 82 or 84 years old. So these patients are going to live 20 years with these metallic stents. So we present a 10 years outcome. If I have 20 years outcome, almost all of them should have been a re-intervention.
Well, if I invite you back again, will you come?
We enjoyed this meeting and this discussion.
Thank you very much. I really appreciate it. And what we're talking about here is in the JACC Interventions, and it is for the August 22nd issue. Please look up the paper and the accompanying commentary. For Cardiol Source World News, I'm Executive Editor Rick McGuire.